Can you hear me? Does that work? Can everybody hear? Because I know that some people who may be a little hard of hearing may not be able to hear. Can everyone hear? Just want to make sure you can hear. Don't be afraid to put it a little bit louder. Okay.
Eve can't hear.
Yeah, no, that's.
Does Dave want to come and sit here?
He's coming. He's standing on the road waiting for.
Now, is that better? Is that better? Yeah. If David can come over here, maybe, and then now we'll be here too. Right. As you can see, this is a very hastily put together discussion, really, because we've only had just under 3 weeks to consider the wording that's been put before Parliament, which will be voted on Friday. One interesting little bit of statistic you might be interested to hear is that you may remember under the Labour government, they spent 700 hours debating the banning of fox hunting, and there are 5 hours allowed on Friday for this issue before a second reading. So that's one curious fact that we are in today. So I'm delighted. My name's Robert Toone. I'm a barrister, but that doesn't really qualify me to be a chair, but that's what I do for a living. I'm here just simply as a kind of a facilitator. We want to thank Dr. Philippa Armstrong, who sits on my right, who is a consultant in anaesthetics and pain management, and she is the clinical lead for pain services in York and Scarborough Hospital of the NHS Trust. So she looks after people in chronic pain and other pain. On my left, we have Dr. Greg Black, who many of you will know. He is a partner at the Ampleforth and Hovingham surgeries, and he's kindly also agreed to speak. En route is Sunita Daniel, who is a consultant in specialist palliative care at the York Hospital. And she is covering also palliative care in the community, because the current care in the community palliative consultant is on maternity leave. So she has experience of that as well. So before we start, I think it's important to set some ground rules, because this is a very emotive subject. I think we can all agree that people suffering in agony is the last thing that anybody in this room would want, and that we are all approaching this from a perspective of kindness, care, and humanity. So while we may disagree about how that is delivered, I hope that tonight we can firstly acknowledge that there'll be many painful experiences probably in this room. Many of us will have watched our relatives die, some perhaps with degrees of palliative care or pain relief, and we want to acknowledge that, but also to say that if we can, and I hope we can disagree well, and we can allow each other to be heard and to be respected, because at the end of the day, that is what it's all about. And that is why these good people who work day in, day out to alleviate our suffering and make us healthy, that's why they've come to give their time. So that's a bit of an introduction. I'm going to hand round a notepad, and if you have any burning questions, would you write them down on that piece of paper? So I'm going to hand that round now. And if anybody, if you just want to write down a question, if you've definitely got one, at the end we may take questions from the floor, but we will have limited time, so we'd just like to make that available to you. Okay, so first of all, we're going to ask Dr. Greg Black just to speak a little bit about how palliative care and pain management and that sort of thing is delivered from a local area, because the first person you will get to see will probably be somebody like Greg or one of his doctors in his surgery. So I'll just pass you over to Greg. Okay, thank you, Greg.
Right,
stand up for you. Yes, so somehow I don't really know how I've ended up here, but there we are. Yeah, I'm a GP in the practice here in the village, if you don't know, and it's quite different, I think, here in a very rural community from how it is in central York or even in Scarborough, where we are much further away from the hospice and the specialist services, and people who are sort of entering their last weeks, months, or even days of life are not able to access those services so easily. The service is quite complicated, and there are a lot of people who are involved in delivering palliative care in our community. So there's the GP surgery, which is often where people start, but also we're very heavily reliant on the district nurses who visit regularly. We do have specialist cancer nurses who come out, or what used to be known as the Macmillan Nurse Service, who come out for us from Scarborough. And it used to be a situation that it was hard luck if you required a visit from them in the end of the financial year once they'd spent their travel budget. But they are very sort of kind, accommodated people, and they go well above and beyond in the work that they do. We do have access to services in the hospice, and those are predominantly we sit within the Scarborough Whitby Ryedale area, and the St Catherine's Hospice in Scarborough is our primary hospice. But people can access St Leonard's in York if they wish, but that's always by special arrangement. We've been struggling with palliative care services in the community for the last 10 years or so. I was on the CCG at Scarborough, and we were pushing for years there to try and bring out the service that they get in the town to our rural community. But there was always a difficulty with finding the staff that were able to come out to this area. And the problem in all rural areas is that it's much less efficient to deliver services. What tends to happen is when there's a shortage of staff, they get concentrated in the larger populations where there's not so much travelling, and more service can be delivered with fewer people. So we always are sort of the poor relative when there's a squeeze on services, and that was particularly so with the palliative care service for us. At one stage, we did have the Marie Curie nurses coming out to patients locally. Now, they often sit with people overnight and provide supportive care. But I haven't seen a Marie Curie nurse for many years. I'm not even sure they still exist. We've given up trying to get that service just because they weren't available to our patients. I think you could get them in Malton, you could get them in Thirsk, but they wouldn't come out to us. But it is dependent on a charity to deliver that service. A lot of the palliative care funding is dependent on charitable donations. There is some NHS funding for the hospice and for the specialist nurses, but a lot of it is dependent on the charities. So we as a practice are lucky at the moment in that we have very dedicated doctors. Dr. Howlett will often be out over Christmas or whatever visiting people for palliative care, because the out of hours is not able to respond in a timely manner. So there's the GP out of hours service, so there's a district nursing out of hours service, but they are stretched across a vast geography, and sometimes it can be many hours. So I know last Christmas, Dr. Howlett was visiting people on Christmas Day and Boxing Day who needed care and weren't able to get it through the commission service. And so she, on her day out off, she was that. We also have, we're fortunate to have Dr. Jacobs, who is a specialist in palliative care as a GP specialist and works in the hospice in Scarborough and I think it's in Middlesbrough as well. So that's where he is when you can't get an appointment with him here. So we're fortunate to have these dedicated people, but a lot of the work that they do is additional, above and beyond, you know, when they're not supposed to be at work, when they're supposed to be resting and preparing and not burning out. So but that's how the NHS works to an extent. That's it depends on a lot of goodwill from people, and there's a bit of a shortage at the moment because it's been abused, but that's a separate subject, not for tonight. If you've got any, do you want to take questions
No,
now?
I think we'll take questions at the end.
Right,
So
okay,
yeah,
fine.
that's fine. If you've got questions.
Okay, I'll hand over then.
Great. Thank you, Greg. That is an interesting reflection that you've given, which is that much of the palliative care, certainly in hospice, is provided by charitable donations, which I think is something that probably not a lot of people are aware of. And so there's funding gaps there. So I think, Sunita, it's so lovely that you've come to join us. So pleased and thank you for doing that. I know you're very, very busy. As I said, Sunita, you are the consultant in palliative care medicine, is that right, at York Hospital? But you're also covering palliative care in the region at the moment, are you, or outside? Yeah, okay. So I'm just going to pass over to Sunita, and I'm going to hopefully get this recorded as well. So I'll just give you the microphone. If you'd like to stand up or whatever you'd like to do, it's up to you. As long as we can see you, that's fine. That's great. Okay.
Hello, everyone. My name is Sunita Daniel, and I'm the consultant in palliative medicine at York Hospital. But I actually also cover the York community. And right now I'm covering Scarborough Hospital also, because we've got shortage of consultants. So we had a consultant in, York Hospital traditionally only had one single consultant covering the hospital and community for years, who was my predecessor. And, once she retired, the post was vacant. And I think they couldn't recruit for about 8 or 9 months. And I was, for my background, I was trained in UK, but actually I spent 5 years as a consultant in India. So due to family reasons, I was working there. And then I decided to come back to UK. So I applied from India and I got this job in York. So that was like an empty post at that time. And at that time, they also decided to recruit a community consultant for the first time. So we've been trying for years to get a consultant to help the community, but they wouldn't. And finally, they did it. But then that consultant has gone on mat leave now. And unfortunately, we couldn't recruit the job. So I'm covering community also. In addition, the Scarborough Hospital, which was only covered by the Scarborough Hospice consultants for a long time. We never had a consultant. We don't have a consultant in Scarborough Hospital at all. Unfortunately, Scarborough Hospice consultant has also resigned, and there is no consultant there. So I'm covering Scarborough Hospital also. So that's what that's a reality situation. And as you all know, palliative care, we provide everywhere. We provide hospital, we provide in hospices, we provide in community, and we try. What we want to do is try to provide more in community, because we all know, as we all probably want to die at our home, isn't it? We don't want to die definitely don't want to die in hospital, definitely don't want to die in ICU, but we all prefer to die at home. But how do we do that? How is it possible? Because we need to provide the best possible care at home. And that's the challenge we are facing. And hospices, as we all said, we've got 2 local hospices. One is St. Leonard's at York. It has capacity for 20 inpatients, but they can only look after about 8 to 10 inpatients now because of staff shortage, financial reasons. Scarborough, again, I think it's a 16-bed hospice, but I was a trainee there before only taken 8 to 10 patients. So there are facilities where you can look after, but you can't manage that because of financial reasons. And so, and hospice always have a long waiting list. We struggle to send patients from hospital to hospice because of long waiting lists. People, they all want to die in hospices, but unfortunately we're not able to do that. When we talk to hospice about that, what they're saying is only 30% of the funding comes from NHS. So it all depends on the charitable funding, and that's also depends on the goodwill of people, isn't it? So that's the reason, if palliative care is properly funded, we'll be able to provide a better service. Now, I've got a bit of evidence, and I'm sure you all know that it's not just cancer patients that need palliative care. That time has now changed. So we look after not just cancer patients, we look after end-stage COPD patients, so respiratory illness, end-stage heart failure, end-stage dementia patients, end-stage renal failure patients, or kidney failure patients, and end-stage liver failure patients. So it's not just cancer patients that need them, because studies have shown that just like cancer patients, the other conditions also towards end of life have got their needs. But the problem with such patients is nobody realizes they need palliative care. So I would say cancer is much more supported because they've got a bit more support with Macmillan team and things like that. But the non-cancer is the one that struggles because people don't identify that they need palliative care needs. They don't refer enough, and therefore they don't get the support. But we want to look after them also. So that's first thing. Second is we've got lots of papers and publication to show that if specialist palliative care, if it's delivered properly, it works well and it improves the quality of life. And the evidence is actually similar to cardiac rehabilitation. So everybody knows about cardiac rehabilitation and it works well. But actually, specialist palliative care, which is a multidisciplinary team provided not just by doctors, but by nurses, physiotherapists, spiritual care team, occupational therapists, chaplains team, all those teams come together to provide the specialist palliative care team. And that sort of support has got good evidence, just like cardiac rehab, but how many know that and how is it funded? So that's the first thing. So if all people get specialist palliative care, we can provide better quality of care. Now, this paper also showed that the patients that are coming to the services, they are referred too late and too little. So we, one of the studies that a national study was done in the UK, which analyzed about 40,000 patients, and the median number of days before death referred to palliative care was actually only 48 days. So these patients are seen by us only 48 days before they die. It is slightly bigger, longer for cancer, 53 days, but it's only 27 days for non-cancer. So our evidence shows that we need at least 3 months of palliative care input to show a benefit. So why are these patients suffering? Because they're not identified enough, they're not referred on time. So that is the other thing. And another important thing that palliative care can do is we pick up the complex cases and thereby we prevent hospital admissions and the burden of the NHS comes down. So one of the work that I have started to do once I joined the hospital team was to have a palliative care presence in emergency department. So normally, as a hospital palliative care consultant, how I work is we get referrals to other specialties. So I don't have my own inpatient beds. The other specialties, especially cancer and cardiology and respiratory, has referred patients to us, and that's how we get involved. Now, we started a pilot project whereby we send a nurse to the emergency department every day to identify the patients, and that actually increased the referrals, and we were able to remove non-cancer conditions because the presence of a palliative care nurse was able to sort of identify the patient's palliative care needs, especially non-cancer, and it also helped us to identify them, better manage them, end of life care in hospital, also refer them to hospice straight away. So patients don't want to die in hospital, they would prefer to die in hospice. So we were able to liaise with the hospice team and refer them straight away. But we can only do that 5 days a week. Because according to the funding of our hospital, they think palliative care stops at the weekend. So we are struggling to, and the reason we started doing that was just to show to the hospital management that we make a difference. We've been showing that for 2 years, still our staffing hasn't increased. We still haven't got enough funding to restart the 7-day service. And every now and then patients suffer in hospital over the weekend because there's no palliative care. They come to us with complaints. We try and address that, but still we don't have enough funding to increase the services. So that is the sad reality of the palliative care service in a hospital setting. Now, I think we discussed about the funding also. So NHS funding. So the important thing to remember is that funding is another important service that Philippa might talk about is the intervention, pain intervention. So lots of patients, when we see they are suffering, and suffering cannot be managed with medications. We can do things like interventions. So that is something that we jointly do with the pain team, and Philippa might talk about that. And what we've seen is that suppose the pain is not getting any better with medications or they've got side effect, we can do things like nerve block. Again, these are done by the anesthetics and physicians with the intervention technique, but palliative care team can identify such patients and refer them. But we need more support. We need more support for as consultants to actually work as rota. So Philippa might say, we take turns to go to patient's house to refill the pump. And they have done that during Christmas time. They have, she might say in detail about that. So again, we need more people to actually run the service and more sort of resources to bring it forward. And thereby we can relieve suffering of such patients. And more challenge, what we've seen is that about other data shows that 90% of deaths would benefit from palliative care, and need is going to increase by 2048 by 20%. So currently in our hospital, we are only seeing about 30% of patients are dying, and the evidence shows that 90% need that support. So if there's more funding for us, at least in my hospital, what I'm planning to do is to obviously go to emergency department 7 days a week, post one nurse there, so you can increase the referrals to specialty. Attend the board rounds of different consultants in the hospital. Thereby identify patients who can go home early, identify patients early with palliative care needs, get involved, manage the symptoms, have a better quality of life. All this actually needs more support, and support to the hospital comes from ICB, and I suppose the ICB comes from the NHS, from the government. So that is where the government probably needs to put more effort in. I think that's all. Any questions?
Yeah.
At the end.
Thanks, Eva. We're going to go for questions at the end, I think. So if you have a question, if the notepad's in your way, write it down. So next up is, thank you very much, Sunita, that was great. Next up will be Philippa Armstrong, who is the head of pain management services. I haven't got the crib sheet, so I can't remember the exact wording, but anyway, Philippa can but she works at York Hospital and covers the region, the whole region. So thank you, Philippa.
Thanks, Robert. I guess I should stand, thing as the other two. Yes, so I'm Philippa Armstrong, and I am a consultant in pain management. So what that means is I'm not just involved with people at end of life. I'm involved with people who suffer with pain, all sorts of different types of pain throughout life. So any kind of chronic pain that can't easily be resolved with a quick fix or an operation. And there's quite a lot of it about. I do support the palliative care teams, though, with, as Sunita said, interventions to try and relieve pain at end of life as well, where medication hasn't worked. And I'm quite keen to put a little bit of a more positive spin on things than I think. You've heard about the struggle that palliative care is under, particularly in our rural communities, and being able to deliver a good service in this area. We know the reality of it is very hard. However, the UK on numerous surveys comes top in delivering palliative care across the world in the areas where they are delivering it well. I know from the interventions that I can give to patients that we can make it even better. For the patients that don't respond to the medications, that aren't getting that relief, mostly through the strong opiates, there are interventions that I know I can do, and people like me can do, that will help those patients as well. If we could get the right funding to deliver it. And I'm not ready to give up on the fact that that's not possible. I'm not ready to say, do you know what, we can't do this, let's just kill people. So I'm very passionate that this is possible, that we can do this, but we need to have the funding to do it. And one of the things that worries me about this bill is that it's coming from palliative care funding. And the only stipulation is that people should have been offered whatever is presently available in their area, as opposed to trying to deliver a really good service right across the UK. So that's where my concern comes from it, because the other studies have shown that the majority of the NHS budget is spent on people in their last 2 years of life. It also shows that actually, although I think there's been a study done by the Care Not Killing group back in 2014 that said it's fairly constant that 70 to 80% of the population support assisted dying, and that's been the case for about 10 years or so. So when they're saying, well, this is, there's been a change, there's a lot of people that are now supporting it who didn't, I think that's fairly constant for at least the last 10 years. But what it also showed was when people understood what their full options for palliative care were, the majority of people changed their mind. And that's why I've asked for this meeting, so that you are aware of what palliative care is, what end-of-life care is, and what the options are available. Some of you may have had sort of personal experiences, obviously, but there is stuff that we can still do and we can do better. And I'm not ready to give up on that. So when we talk about palliative care and end of life, we tend to focus on the pain, but that's not all it is. And pain and suffering, in my role as a pain consultant, it's standard for us to talk about pain in what we call a biopsychosocial model. So there's only part of pain is physical. It's really important that if you're going to address people's pain, that you look at the psychological and you look at the social impact and the fears that they have surrounding pain. And you can't deliver that as a purely medical model. It's not just about the medications. It's not just about the interventions. You have to address people's fears. You have to address where they are in life. And you need to deliver that through a multidisciplinary team of nurses and psychologists. And the palliative care, specialist palliative care teams do that extremely well when they're able to deliver it. So I think it's really important that we remember when we're talking about end-of-life care that it's not just about physical pain. Physical pain, in a way, is the easy part, and it should be the part that we can deliver on relatively easily. So I come at this in two ways. I have a lot of colleagues who I know, very compassionate people, would say, I think we've got to give people a choice. Surely it's autonomy. It's all about autonomy. People ought to be able to say they've had enough and they want to die when they've got a terminal illness. And I would agree with that in many ways, but my big concern is that one person's autonomy has an impact on other people's ability to choose as well. And we live in a society where we want to look after the vulnerable. We have what we call relational autonomy in the most part. We never have a complete right to choose what we want to do. And I think it's Matthew Dorey who has a lovely little video where he says about, he's the secretary of the Association of Palliative Care. And he said, we all abide by speed limits. We abide by speed limits because it's good for the community that we do. We can't drive at any speed we like because it might affect other people. And that's just accepted in law, that when we make a law, we can't just do it for the individual. We have to think of the community as a whole. And it's very difficult, the ins and outs of this law, it's very difficult to identify who is making this choice freely when they choose to take the option of dying without any coercion, and who has the mental capacity to do so, and it's not going to change their mind should they get good palliative care. And for that to try and be decided upon by two doctors and a judge in a timely fashion, so that it's actually appropriate, is pretty unrealistic, I would suggest. And that's one of my concerns about it, that there's a lot of people that may end up taking this choice or being given this or opting for this choice, who potentially have had some kind of coercion. And there's lots of studies to show that there's about 1 in 5 people over the age of 65 who have had abuse. We don't all live in lovely, happy families with everyone's got our best interests in for us. So that there is that potential there, and doctors are not very good at picking it up, to be fair. There's also, and I think we'll hear from Larry in a minute from Canada, good examples of, I think they're investigating between 2,000 and 4,000 deaths that have taken place that they think have been wrongful deaths. And that to me is like, if that was the number on death row who had been wrongly killed, I think we'd all be a bit scared about that. So those are one of the issues. It's about the autonomy, the impact of our own choice on other people around us. And also my big fear is the way it will change the doctor-patient relationship. My vocation, my job is to care for the patients that are in front of me, to hope that they trust that I will always have their best interests at heart, and that I believe that their life is valuable and worth saving and alleviating their pain. And I feel it's really important that they always know that that's what I think. Sometimes you need your doctor to think that, even when you don't yourself. There are times when many people won't be able to see a way forward or a way that they can go on, and I think you need other people to believe in you in that time as well. So that's where I am at. I'm going to sit down.
Thank you so much, Philippa. That was great. We're going to hear from Larry Worthen in a minute, but I just thought you might be, as I am a lawyer, I thought I'd just give you, I'm not a specialist in this area, but I've read the opinions of people who are specialists in the area, and I know a little bit, and I've read the Act myself. And I'd just like to highlight two or three things to you, which I think you might find interesting. First of all, the definition of those who qualify is not by reference to an index of or a schedule of diseases, incurable diseases that you may suffer. It's a very vague term, and that's been criticised by both doctors and lawyers alike. Secondly, as Philippa highlighted, you are given a choice of what is currently available. So that's very important, because it really takes the pressure off government and the NHS to provide those services for you, because there's always a get out, because ultimately if killing is a therapeutic option, or if ending your life is a therapeutic option, why do you need to offer palliative care? Because that does the same job, if you like. And thirdly, there's quite a lot of opinion being voiced. You may have heard this morning on Radio 4, and also there's a letter to the Telegraph by a former Chief Coroner. So this morning, the formerly Lord Chief Justice said this Act is unworkable. There's been no costings of the impact of how much work this would create for the judiciary. There's no mechanism or procedure to work out how the judge is going to work out whether or not you are under coercion or have been coerced, or that's a reason why you're going forward with this treatment. And this is my own little comment on this, but I read the legislation, and it's in the opinion, to the best of a doctor's knowledge, that he writes a thing saying, to the best of my knowledge, this person isn't under coercion. And that's very worrying, of course, because imagine a busy doctor. I mean, we know how doctors are at the moment. They have to, how much time are they going to be given to make that judgment about whether you're under coercion or not? And is a doctor really qualified to make that judgment? Have they any training? Are they going to be given any training? It's a fact that when people make their wills after the age of 60, that there's specialist training given to the lawyers who do that in order to spot coercion, because that's something that does happen. I think
with the slides in the background.
Sorry, I just need to. Yeah, Larry's coming on in a minute, so he's just doing a check here. And the other thing that I'd like to, so the Lord Chief Justice, former Lord Chief Justice, was expressing those. I think he retired in 2017, so not long ago. It's interesting that Parliament hasn't asked or published the opinions of the current Lord Chief Justice, the current sort of head of palliative care, or because that's very important as well. And I think many people are probably feeling they have to step back and be neutral on this issue. But finally, the chief coroner, former chief coroner, wrote a letter saying that and I'll get the right section for you in a second, but section 29 is effectively means that if somebody has died as a result of this process, any coroner cannot subsequently look into the death to see if it was a wrongful death. So we talk about safeguards. That's the ultimate sanction, isn't it? A posthumous look at a death to see whether it was properly carried out. There won't be any inquiry allowed into that. And he was raising that point that that's a powerful sanction that's actually been deliberately removed from the Act of Parliament. So I just want to raise, those are some of the issues. And I suppose my only reflection is why is only 5 hours being allowed to debate such an important step? And I think there is an amendment going forward, which is designed to point that out and to prevent a second reading on Friday. But if you feel at all one way or another, to be honest with you, if you feel, I think you should perhaps consider making your voice heard to our local MP. Because at the end of the day, we live in a parliamentary democracy, and if we don't participate, we end up with the results that we deserve. Okay, so those are just some of those legal issues. I just thought also I would point out that Wes Streeting, the Health Secretary, is obviously against it because he's worried about the impact of care on the rest of the system. And the Justice Secretary is also against it. Again, probably for the reasons that Sir John Mumby, who is the head of the Family Division, which will actually be dealing these cases, is suggesting that it will be an extra 34,000 extrajudicial hours a year that will be required to properly consider the cases going forward. So they talk about the system's broken, both the justice system and the NHS system is broken, and then this is going to be put on top of that. So these are all very important issues, which, whether we agree or disagree with the principle of helping somebody to end their own life, are important issues in order to safeguard those who might be vulnerable to coercion. So I'm going to hand over to Larry. I'm going to have to do two things: plug him into the screen and also introduce him at the same time. So bear with me. But I met Larry. I had the pleasure of meeting Larry. I was in Canada a couple of weeks ago, and I had no idea of the situation in Canada, but he brought me up to speed. He is the executive director of the Christian Medical and Dental Association, which looks after, I think, 1,600 doctors and health professionals, the length and breadth of Canada, and offers them support. And he has been working alongside them since the introduction of MAID, which is medically assisted in dying. That's what it stands for, since 2016. So he's highly qualified to talk about the situation in Canada. And I was looking online today for another legal opinion, and there were two very eminent KCs, one who's just retired, who was the public law KC of the year in 2020, and another lady who's also very eminent, working in landmark chambers. They wrote a blog, and they didn't express an opinion either way in favor of or against assisted dying. But what they said was this, that if we want to find out what assisted dying will look like in our country in the years ahead, we should look to Canada, because Canada has a similar jurisdiction and common law arrangement. And that so that was two leading public law KCs who work out of landmark chambers, who are very well qualified. So we are very privileged to have somebody who knows a lot about Canada and who will be able to tell us about what has happened in Canada since 2016. It was an absolute pleasure to meet Larry, and I'm going to hand him over to you. So I'm going to turn this microphone off. Thank you.
Robert, thank you for the warm introduction. And
yeah, just hang on a minute, Larry. Hang on a minute. hang on a minute, 'cause I've got to plug you in. It's a bit homespun around here. I'm
Okay,
afraid.
no problem.
Can you do your slides? Is that okay or not? Or are you doing them in the background?
No, my slides should be okay.
Okay.
Can you see them?
No, I'm just. Right. Turn it on and off again. Okay. Larry, can you hear me?
I can hear you fine, Robert.
Great. Okay, so I'm going to hand you over, and hopefully we can get some volume going in here. Yeah. Can you just speak?
Testing, testing,
Okay,
testing.
it's fine. Okay. I think, can everyone hear or not really? Okay. Yeah, just give me a second. Audio settings. There we go. Okay, can you speak now?
Testing, testing, testing.
Yeah. Brilliant. All right, that was.
Wonderful, Robert. Can you see my slides? Okay.
Yeah, in the background. Yeah, we should be able to.
Wonderful. Okay. Well, thank you very much, Robert, for the warm introduction. It certainly was delightful for me to meet you a couple of weeks ago, and so much has happened since then. And we're just pleased to have been able to make a contribution to the discussion in the UK. What Robert said is absolutely right, that if you're from the UK, I really believe you need to look at what's happened in Canada, because in 8 short years, a lot of dramatic changes have occurred. Changes to healthcare, changes to values, changes to medical ethics. And these things are all important considerations as Parliament debates your bill on Friday of this week. First of all, just a bit of clarification on terms. MAID, medical assistance in dying in Canada, consists of euthanasia, where a patient dies by lethal injection, and also assisted suicide, where a patient dies by taking lethal medication. My understanding of the legislation in the United Kingdom is it's proposed to be an assisted suicide regime, but in Canada, about 99% of the deaths that happen are by lethal injection. How did we get here? Well, in Canada, we have a slightly different constitutional system than you have in the UK. In Canada, in 1982, we passed legislation. We patriated the Canadian Constitution from Westminster. And at that time, the courts were permitted to institute a Charter of Rights and Freedoms, and to a limited extent, to have supremacy over Parliament under certain conditions, and also to be legislative. And that's what's happened in this case. The courts made a decision in 2015. In 2016, it went to Parliament. Parliament implemented part of the court decision, but then when they put restrictions, similar to what you have in the UK with this legislation, there was a restriction against non-terminal illnesses that was overturned by the courts. We allow for pre-qualifying for MAID, so that someone can qualify for MAID today if they're thinking they might lose their competency. And by 2027, people will be able to die by MAID if their only presenting illness is mental health. This is an important lesson, I think, for you to look at in the UK. I am by no means an expert on the laws of the United Kingdom, but I have read legal opinions that suggest that while in the UK it would be impossible for the courts to initiate assisted suicide, that they suggest that once Parliament passes assisted suicide legislation, then they would be open to appeals to the courts in the UK that would say that you're discriminating against other groups if you restrict euthanasia or assisted suicide to just people that are terminal. So these lawyers are suggesting that even though there is a narrow restriction in this legislation, that is possible for the UK courts to expand that down the road. And that's certainly what's happened in Canada. And currently, euthanasia and assisted suicide has accounted for 60,000 deaths. And Robert very kindly shared with me that the Ryedale District Council, which I think is the geographic area that you're situated in, has 55,000 people. So to give you an idea, there would be 60,000 deaths in Canada since 2016. Now, where are we going? The Parliament has already recommended that MAID be open to mature minors. And currently one of our children's hospitals has said that there's no lower age limit on that. And in addition, there are protocols in place that would say that parents could not stop a child from dying through euthanasia. Quebec, one of our provinces, has already said that they are going ahead with advanced directives, which is extremely problematic. And the federal government has decided not to stop them from doing that, even though the criminal law is federal. And certainly at this rate that we're going, the expansion that has taken place and the people who can access assisted suicide, we fear that we are headed to the point where eventually someone will come and say, I'm able-bodied. Why do the courts discriminate against me? Why can't I get MAID? And so that's the concern of where things are headed in Canada. This chart will show you in very clear graphical form how quickly euthanasia has grown in Canada. The orange line here is the Netherlands, which has had some form of assisted suicide since the 70s. The yellow line is Belgium, the white line is Switzerland, the green line is California, and the red line that is moving so quickly is Canada. These statistics only go to 2022, and I have projected, and others have projected, that by this time, 2 years later, almost 2 years later, that Canada is probably #1 in the world. In fact, even in 2022, two of our jurisdictions had statistics that were larger than the Netherlands. The British Columbia, which is our most westerly province, and Quebec, both of those had statistics that indicated that they were euthanasia was being chosen at a higher rate than even in the Netherlands. So what's wrong with euthanasia and assisted suicide? Well, first of all, it endangers people who are experiencing vulnerability. I'm going to talk some more about that later. The second thing is something that Robert spoke about. If death is a therapeutic solution, what's the incentive to do anything else? So your health system is similar to ours. It's socialized medicine funded by the government. And I think that it's fair to say from what you're describing is that, there's a need for more resources. There's a need for more resources in Canada. And certainly there's pressure being put on the government to provide more resources, to provide more effective healthcare and consistent healthcare throughout the country. But if death is accepted as a therapeutic solution, an ethical response to suffering, then what is the incentive to do anything else? And finally, it's an important factor for Christians and other people of faith. We are not the authors of our own lives. So I'm going to talk about these individually. There were earlier presentations that talked about the reasons people choose euthanasia and assisted suicide. The general public thinks it's because of serious pain. The typical person they think of is the patient who's in their late 90s or early 90s, dying from metastatic cancer, in extreme pain, begging to end their lives. That's really not factually correct in the majority of circumstances. Palliative care physicians in Canada tell me that almost all pain can be dealt with at end of life. And in actual fact, the reasons that people choose are here on this graph. Loss of ability to engage in meaningful life activities, over 80%, loss of dignity, over 50%, perceived burden on family, friends, or caregivers, over 35%, isolation or loneliness, 17%. What do all of these factors have in common? What they have in common is that with support, counseling, care, and proper palliative care, which provides all of these things, that there would not have been, that the suffering that the patient was experiencing would have been alleviated. Even our category around pain control talks about inadequate pain control or concern about inadequate pain control. And we don't have specific statistics on the people who are actually not having their pain controlled. It may be that the people in this category are mainly concerned about that. I want to talk in particular about vulnerable patients. About a month ago, a wonderful lady came to speak with us who had she had suffered from disabilities her whole life, from the time she was a teenager till her adult life. She's now 51 years old. She found a breast lump, which was cancerous. She decided to have a radical mastectomy, and then had the second breast removed about 7 months later because of for preventative purposes. During those two mastectomies, she was approached 3 times about whether or not she wanted euthanasia. And she got to the point where she no longer felt that the hospital was a safe place. And she went out, as soon as she was well enough, she went outside the door of the hospital, sat on a park bench, put her head in her hands, and just burst into tears. You see, again, this is the issue. Once you say that euthanasia is a therapeutic option for patients, then it begins to be treated like any other option. It is a lethal option. It should not be treated like every other option. And in this case, these healthcare providers were feeling like they were doing her a favor, seeing that she suffered from disabilities. One of the doctors brought up the issue of euthanasia with her when she was on the gurney on her way to the OR to be operated on. So this will give you an idea of what you may be looking at if this legislation is passed. The second concern is, as I said, once it becomes a therapeutic option, what is the incentive to do anything else? If you look at the 3 categories of people that fall under Canada's current legislation, those who have a terminal illness, well, we know that in Canada, only 30 to 50% of Canadians have access to proper palliative care. And a similar situation, I think, your statistics may not be this bad in the United Kingdom, but I certainly heard that there's a disparity between the services that are provided in urban areas and the services that are provided in rural areas. And certainly, people in rural areas should not be more prone to choosing assisted suicide than those in urban areas. That just doesn't seem to be fair. And again, it goes back to what one of the physicians said earlier in this presentation, when she said, how many people are making free decisions? Well, if there are no options, then how can the person be said to exercise a choice? Secondly, we also allow euthanasia for persons with disabilities. 1 in 5 Canadians have disabilities, and persons with disabilities experience the highest rate of poverty in Canada. Often I say that the point that I make is that MAID in Canada was really designed for people who perceive that they have independence and autonomy and who are privileged. But if you're not wealthy, then you have a more difficult time getting access to services, and therefore you don't really have a choice. And finally, on the issue of mental health, which is of real concern, in 2027, when MAID is open to persons with mental health concerns, there'll be a 3-month waiting period to access MAID, where currently in Canada, there is a 6-month waiting period on average across Canada to access a psychiatrist visit. So we'll be making it much easier for a patient to die than for a patient to get proper mental health care. And so these are very real concerns as well. The most dramatic example we have of the inadequacies of the Canadian healthcare system and how MAID was used in a very tragic way is Normand Meunier. Normand is a quadriplegic from Quebec, from Montreal. His wife was a strong advocate. He had a lung infection. He was taken to the emergency room. At that point, there were no beds in the hospital, and Normand had to stay in the emergency room for 5 days. Early on in his stay, his wife warned the attending physicians that if he didn't have the proper mattress, he would get bed sores. They were unable, because of a bureaucratic rule, to bring the particular type of mattress he needed into the emergency room. And Normand got very severe bed sores, resulting in extreme pain. He stated at that point that he didn't want to be a burden on the system, and he asked for medical assistance in dying. And Normand's life was ended because of an inadequate healthcare system that failed to provide him with the care that he most seriously needed. The second patient story is a patient by the name of Sophia. She had multiple chemical sensitivities. She could not find proper housing, even though her friends were trying to raise money to provide proper housing. And what ended up was that Sophia ended up asking for MAID, and she was given euthanasia because of her multiple chemical sensitivities. Before she died, she left a videotape saying that she didn't want to die, but she was doing it because she had no other choice. And this got out to CTV News, which is one of our TV stations here. And this became national news that someone had actually died, not because of the underlying condition, which could have been treated and dealt with, but because of her inability to get proper housing. This is the Ontario Coroner's report that was referenced earlier. There's, again, Ontario is one of the few provinces that allows the coroner to keep an eye on these things. 428 cases were found of possible criminal violation in Ontario alone. And in 2023, the coroner's office raised concerns for a quarter of all euthanasia providers in Ontario. 29% of reported Track 2 cases involve patients living in poverty. Track 2 cases are cases where death is not reasonably foreseeable, disabilities, chronic conditions, those sorts of things. 29% of those patients were living in poverty. So these are some of the concerns that we have seen. If I may make an observation, the problem is that when you're going to legalize these things, the push is on to legalize things, the proponents bring you the most difficult cases of all. They're always patients who have support from their families, support from the community, they're articulate, they're capable, they're independent. But when you allow euthanasia to take over, then you find that it is some of those patients, but many of the patients who are choosing this are choosing it because they don't have alternatives, and often that is because they don't have the means to get the services that they need. The Christian perspective. Well, there has been, for over 2,000 years, a prohibition against physicians ending the lives of their patients. This comes from the Hippocratic Oath, but also it has been supported by the Judeo-Christian concept that killing is wrong. And the reason killing is wrong is that that rule is there to protect the vulnerable. It could be very tempting to end someone's life when they're very vulnerable, when even they can't see a reason to live. But often it is the caregiver who can come along, and by listening, by supporting, by providing a caring ear, can help that person begin to see that their life, in fact, is worth living, and that they do have dignity and value. As a Christian, I believe that dignity and value comes from God, and it can't be taken away by any organization or by Parliament or any other legislative body. It's a dignity that's unassailable and should be supported in our healthcare system. And for Christians, Jesus says, whatever you did for the least of these, you did it for me. That is, Jesus Christ in the Christian faith, the Son of God, actually identifies with the vulnerable and the needy. And so when we care for those people, whether in palliative care or other healthcare situations, we're actually caring for Christ in the Christian perspective. And I often say jokingly, I'm a lawyer, but I can't find a loophole in this statement. If you love me, you will keep my commands. And the commands of God are to protect and preserve life, even for the most vulnerable. This is perhaps the most disturbing thing, or I shouldn't say the most disturbing, a very disturbing thing I'm going to be sharing with you today. Our medical regulators are province-wide, so each province in Canada has its own medical regulator. Our medical regulator in Nova Scotia has decided that doctors, physicians must provide an effective referral for patients who come to them looking for euthanasia. A referral for many Orthodox Jews, devout Roman Catholics, evangelicals, and others, a referral is tantamount, morally tantamount to actually providing the service. So the fact that the college here requires this effective referral and has insisted on it has meant that there are 42 doctors here in Nova Scotia who will be unable to practice. Now, currently, euthanasia in Canada has become such a sacred cow that the politicians are really unwilling to challenge the regulator on this. And so we're in a bit of a standoff here in Nova Scotia at this time. But think about it. Once you accept that it is ethical or morally appropriate to end the life of a patient, then if a physician will not end the life of a patient, then there's something wrong with that physician. And that's the logic that is certainly being used. And the concern is that if we lose these doctors, then will they, who will be there to provide alternatives for patients? I must just say one thing too in closing, because we have some palliative care providers there. Our palliative care physicians in Canada have been, I would say, traumatized by the legalization of euthanasia in Canada. A couple of reasons for that. One is that often they are criticized by their colleagues and even by family members if they speak to a loved one who is considering MAID and that person changes their mind. I've heard numerous stories where they would speak to a patient who might have already been booked for MAID, and that patient changes their mind, then the physician themselves get criticized by colleagues and the patient's family for quote unquote talking the patient out of it. I've also heard there have been 2 documented cases of health authorities in Ontario, large health authorities, where the government has said to the palliative care group, you must develop a MAID service within your current budget so that funding is directly being siphoned off from palliative care into MAID. And then I think the third concern is that government sees MAID as part of palliative care. And this is a tremendous violation of the ethics of palliative care. The whole purpose for palliative care in the beginning, the government is coming along and saying, okay, because they lump end-of-life care altogether, they see that MAID is part of palliative care. And finally, palliative care hospices in Canada are being forced to provide MAID on the premises. So in the government of Quebec, the government of BC have actually taken legal steps to force palliative care providers in hospices to provide MAID on the premises. This even occurs when they receive no government funding. In one case, a privately operated hospice in British Columbia was expropriated by the provincial government with no recompense to the palliative care NGO. They completely and totally expropriated that facility, and they are no longer able to provide palliative care services within that facility. So that's very brief. I want to thank you for your time. I want you to know that we in Canada are praying for you, and we sincerely hope that this legislation will be defeated and that there will be a strong impetus to provide the funding and support to ensure that palliative care is provided consistently all across the UK. Thank you.
Thank you very much, Larry. Be a bit tricky this, but we need the microphone, don't we? Okay, thanks. Okay, so we have some time left for questions. I'm not quite sure because I can't see the time, but sorry.
29.
Yeah, so of course, yeah. Sorry. So we've got about 20 minutes for questions. We think we'll end at 9, but if people want to hang around and speak to the people here, then that's absolutely fine. But obviously, you want to honour everyone else's time, and people have got something to people have got to get home. But I wanted to highlight one point, probably for Larry, is that Section 4, subsection 5 of the proposed legislation says a registered medical practitioner who is unwilling or unable to conduct the preliminary discussion, which is the discussion about assisted suicide under subsection 3, must, if requested by the person to do so, refer them to another registered medical practitioner whom the first practitioner believes is willing and able to conduct that discussion. So somebody who ethically objects to that for whatever reason, and we know that people, both those who have a faith or who have none, do have and would have an ethical problem doing that. They may well then have to cease practicing medicine in this country because of that section. So again, talk about safeguards. Safeguards for whom? So I just wanted to open. Well, we've got some questions here. I wonder if I think there's a question that I think lots of people want to know the answer to, and it's a generally quite popular question, which is the pain, the examples of extreme pain that are given to us on the news. This is all about these people. Could maybe Sunita talk about how many people's pain in their cannot be relieved by palliative care, and do you sort of mean? So who would actually, in terms of percentage or whatever, how many people are we talking about? Because I think that's often an issue that comes up. I'll look through the questions.
Generally, the pain, there's lots of options to manage medically. So we've got simple analysis. We are familiar with paracetamol, ibuprofen. If it doesn't work, we change to the weaker opioids. And then next option is strong opioids, which we all know, morphine, but there are other options like oxycodone, fentanyl, buprenorphine, so lots of other options. So some people can't tolerate morphine, then you can switch to a different one. So we've got that option. We've got other medicines specifically for nerve pain. So you must have heard of like amitriptyline, pregabalin, for nerve pain. The pain is usually a combination of cancer pain can be a combination of nerve different options. This can be given as tablets, it can be given as injection, it can be done at home, the syringe pump. So what I'm trying to say is that lots of options to manage. And in very few percentage, so maybe less than 5% of patients, sometimes with non-able to manage the pain, which is sometimes because of things like nerve pain or vascular pain. And that's when we think of intervention. So the difficult pain that we can't manage is when we ask our anesthetic colleagues for interventions to go to get nerve blocks, pumps, and things like that. So it's very, very low number of persons that less than 5% patients that usually have difficult pain and it's difficult to manage. And then obviously towards end of life, the pain is difficult to manage. So we have to give medicines to actually make them feel comfortable, which might make them more sleepy, but we do that in palliative care. So as Philip mentioned, the pain can be not just physical pain, it's global pain. So it's a psychological aspect, social aspects, the anxiety towards end of life. So we give medicines that would make them less anxious but more sleepy, but that can be managed in the hospitals. So towards end of life, the symptoms can get worse, but we are able to manage it in the hospitals, and the advantage is in the patient understand what's happening, we start the medications, and we the families with them in a better environment, looked after with the family, the team. And so so it's a very, very load on the patients who have had a great towards end of life.
I'd only answer that in that's when palliative care is delivering as it is now. recent meeting that I went to when we talk about the additional interventions that pain management can deliver. One of the most useful ones, I think, is something called an intrathecal catheter, where you deliver not just morphine but local anaesthetic through the spinal space, and because you're able to use local anaesthetic in addition to morphine, you can get much better control of pain with less sedation, clearer head, and less side effects. Now, at the moment, there are 70 of these intrathecal catheters implanted a year in the UK in total. In York, we implant between 5 and 10 of those 70. So we're one of the few centres in UK that are actually delivering this device at all. The recent meeting that I went to in France suggested that there would be 5,000 people a year that would benefit from these catheters. So we're not even touching a lot of these people. So we're talking about these are the patients that can't be managed on the medications that we already have available to us in palliative care. So we're talking about 5% of people, and then of those 5%, we can actually do a huge amount more for them as well. So yeah, I think there's more that we can offer.
Yeah, I'd just like to add that even here in rural North Yorkshire, we expect to get control of pain for people at home, to manage people at home in a well-controlled environment, and where people are able to naturally pass away in comfort without distress. And that's what we would expect to happen. I maybe painted a bleak picture about the service here and how we struggle, but we do provide a good service in the end.
Yeah. And Larry, can you hear me?
Yes.
Yeah, could you just speak to that from your research in terms of what's the percentage of people that actually would die in pain with good palliative care, or with very good palliative care?
Well, our palliative care physicians say that it shouldn't be happening at all. That most pain can be dealt with at end of life. And in Canada, and I'm sure in the UK, they do have a process called palliative sedation, where someone is actively dying, they're able to sedate them. And the best estimate I can get on that is my physicians tell me it's like between 1% and 0.1% of all deaths. So a very small number might be candidates for palliative sedation.
Thank you. Thank you. I also just want to draw your attention to the fact that although that is the advocacy used to pass this bill, that is not the criteria that is set out in the bill. The one doctor I was listening to a podcast, who was actually an atheist doctor, saying that between 500 and 600,000 people per year will be eligible for assisted dying under the bill. So it is not dealing with a very, very small percentage of people. It's saying it's dealing with that, but it's actually dealing with people who have a prognosis of less than 6 months to live. And it doesn't talk about unbearable suffering, and the patient doesn't have to give a reason. So just to be very clear about what's being proposed and what's being advocated, you might want to see the difference between that. So there's a very good question here. Dr. Philippa mentioned relational autonomy. Please could you speak about the issue of relational autonomy and the pressures that may come to bear on others to not be a burden and thereby feel coerced?
I suppose what I mentioned in relational autonomy is that there are many examples in our lives where we don't have autonomy exclusively, or right to autonomy exclusively to without taking into consideration the needs of society as well. And so many of our liberties are restricted to a degree in order to protect the vulnerable of society as well. So although we all like to think that we have complete autonomy, we don't. In many ways, we are restricted, and we accept that as part of living in a civilized society, I suppose is what I meant by that. And yes.
Pressures that may come to bear on others to not be a burden.
Well,
Have you had experience with that?
So personally, no, I think probably the
Just
other
repeat the
guys, yeah, so the bit was the pressures that may come to bear on others to not be a burden and thereby feel coerced. I'll let the others maybe talk about perhaps personal experience about this, but I think this is fairly obvious. I think a lot of people don't want to be a burden. Hear it from my parents all the time that they don't want to be a burden, and I think that worry that they are taking funds from other people that may do better for them, and that their sense of wanting to do right by the community rather than seeing themselves as equally deserving. And I think that's up to the community and society to disavow them of that sort of concept. And actually, it is part of our experience as well, and in caring for people. And actually, a really good article by Gordon Brown that I've copied and left on the table about the benefits for caring for people for the carers as well as for the person themselves.
Okay, thank you. This is the difficult question to answer, but it's been asked. So, how are we to define capacity and consent, particularly in respect of mental health? Do you want to grab on that one? I need a lawyer. You need a good lawyer on that one. I think that's the real problem. Yeah. Do you want to talk about it, David? No. Okay. No, exactly. Yeah. What were you saying? You want to talk about it? Yeah.
I think that's the question, isn't it? And I think that's part of the issue is that it's not in the bill how that is defined and who's going to be trained to do that, and it's another gap, it's another ambiguity which is going to open the bill to abuse in the future. I do feel that it's the sort of the thin end of the wedge, a bit like abortion was before, and that would just it's just going to expand if this is passed, and that will be one of the things where it won't be clear, and people will be able to push it through with no right to appeal afterwards.
Yeah. Okay.
Robert,
Yeah.
Could I
Please
just
do. Yeah, please do. Yeah.
could I just talk about the situation in Canada?
Yes.
What they did in Canada was they set the level of capacity to be the same as to consent to any other medical operation, like a knee replacement or something, which is a very low standard when you think about the consequences of the decision. And we've had this determination. Lay people may not understand how this is a very much a gray area. We had one case that was documented where the patient was seen by a gerontologist who reassured the daughter of the patient, who was one of our members, that this patient in no way could be seen to be competent. Yet within 10 days, two GPs came in to do the MAID assessment. They felt that she was competent, and they ended up providing her with MAID. So it's a gray area. It's a matter of opinion, and you can definitely do doctor shopping, where as long as the assessors are of the mind that you're competent, then you're competent. So it's extremely concerning situation.
I think in Schedule 2, the doctor's coordinating statement, or the coordinating doctor's statement, has to sign this statement, which is, to the best of my knowledge, the patient has a clear, settled, and informed wish to end their own life, and made the first declaration voluntarily, and has not been coerced or pressured by any other person into making it. So, to the best of my knowledge, there's no procedure set out what tests are going to be required before he reaches that, or she reaches that conclusion. And there doesn't seem to be much extra funding in the budget for this. And certainly palliative care will stay the same in terms of budgetary provision. And I think that's I think what's very key to this is that it's a highly subjective test in the first place. So to the best of my knowledge, so somebody else could, like Lawrence has talked about doctor shopping, doctors who are more in favor of this, they're given huge amounts of latitude. And as the Justice Secretary said in her statement, we know from lots of experience in the past that doctors, public officials, and anybody else, they are not, first of all, devoid of making mistakes or, sadly, making self-centered decisions and decisions that are in their own interest. So, you know, that's just something to bear in mind. Okay, we'll move on to the next question. Yeah.
I actually think it's worse than that, because I think they used the Mental Capacity Act 2005, and that actually assumes mental capacity unless you can prove otherwise. So are the doctors actually supposed to prove that the people that have come to see them aren't actually mentally capable? So I actually think it's actually worse.
Yeah. So the proof is that you need to prove that that's being called coercion as opposed to
Yeah, that was actually, it's worse than having to prove. It puts the burden of proof onto the doctors, which is completely unworkable. And then if they say, actually, I'm going to give you to another doctor, this is a doctor who doesn't know you, who's not a practice where you know the doctors, and then there have to be two of them, and then abandon high-cost drugs if you can find money.
Well, I was looking at the wait for the family course. It's about 6 months. It can take between 6 and 24 months to hear a children's case.
Well, I it's about 6 months. It's just
Yeah.
like I thought was interesting.
Yeah.
Quite new.
Yeah. Yes, exactly. Yeah. But thank you for pointing that out. Yes. Now, this is an interesting point, I think, which says, haven't certain clinical treatments been a form of euthanasia, significant usage of diamorphine, Liverpool pathway, etc.? So I think that's a good question to raise. One that who would like to answer?
So yeah, I think I thought there was used previously, but I think there's lots of misconceptions about that. Basically, in all practical purposes, that was just a piece of document which was used to assess the patient needs who we know are in the last stage of life clinically. So the importance of such patients is basically we stop all the medical tests, interventions, blood tests, observations. We just prioritize on what is needed for such patients, which is just supportive care, nursing care, spiritual care if needed, support with the family, communication with family, and with symptom control. So that was just a piece of document which aided the doctors to actually go through that and make sure all this has been looked after. We need to speak to the patient and the family about the hydration needs, because when they reach the end of life, the needs of the body comes down. So you don't need IV intravenous fluids. You don't need artificial nutrition, you don't need artificial hydration. We encourage the patient to eat as they want or drink as they want. So, but if that document was not there, what would happen was all such patients would be on a drip. You won't have cholesterol conversation, there'll be unnecessary blood tests and things like that. So to prevent that, the document was there. It is not a part, it was just a document, but unfortunately the way it was managed, there was lots of issues, and that's why we had to withdraw that. Now, in that, we have a symptom control checklist. So we expect that some patients, not all the patients, most of the patients have very comfortable and peaceful death with the loved ones nearby, which is what we say as a good death. But few patients could have uncontrolled symptoms, say for example, pain. So we do have a checklist for those symptoms. So the nurses come and check on the patients, do they pain, are they feeling sick, are they feeling breathless, and we write up medications to support or to manage those symptoms. Now, these are the morphine and diamorphine are opioid drugs, which are known and has got evidence based to manage pain and breathlessness. Now, how we manage that, we don't give everybody morphine. We monitor the symptoms. We give them injections as and needed and very, very low doses. And once we know how much they need to make them comfortable, we start them on a syringe diver, again, low doses according to their symptoms. So so basically what happens is that patients are comfortable, they are not having symptoms, and they gradually obviously because they become more sleepy and then they gradually have a pacemaker death. And that's the process of what we just support the dying process with the medications if needed. And all patients do not have them. As I said before, patients can have very peaceful that they die at home, without any syringe driver. So most of the patients don't have them. So the reason you can't compare us with euthanasia is because you don't give a high dose of medications to stop things at one dose. We just manage symptoms and make them comfortable. And the dying process happens naturally. Now, if you don't do that, patients would suffer at end of life, and that's the reason we start this medication. But these are only given to manage symptoms and not with the intention to shorten the process.
Yeah, I'd just say, in addition to what Sunita said, I think the big distinction is the intention. The intention is to relieve suffering, not to kill the patient. We know that high doses of opiates do shorten life, but that is not the intention of giving them, and that is, you need an expert in ethics or whatever to go through that. But the intention of use makes a huge difference to the reasons why you're giving it. I think.
So I think just sort of got 1 or 2 minutes left. I think this is probably the $64 million question. With the lack of funding in the community and an aging community, what will patients do? What are their choices? Lack of staff, beds and care will drive the public to take their own lives in their own hands. Very worrying. I think that also links to another question, which is, could the panel please, if they've not already done so, offer some thought on the advocacy to government for funding to hospice provision? How might greater resources impact this issue? So, but you haven't answered the question for me.
Sorry, that was a bit of a long question.
Yeah, no, if it's really about funding and the fact that there's a lack of funding.
Is it realistic?
So,
Are we realistically going to improve
Yeah,
it?
we don't really have control over that. We do, although we are always aware of the lack of provision, and it's something that we are still working with the local sort of NHS bodies to try and improve. And it's only in the last year or so that we've actually had an overnight district nursing service, which has actually made a big difference. So the people stay at home. The figures are very low in how often it's used, but at least it enables people to stay at home because there is a service that they may be able to call on. So that's been helpful. We are continually pushing to improve the hospice service locally, and we've just, I think, in the last 6 months, access to hospice at home, which comes from Scarborough. That's right, isn't it?
Yeah, we're just checking.
And also, if we are part of a network of practices, so locally, if we are working with Derby practice in Walton, Sherburn, Willington and Snayton, and to try and improve services locally, we'll have a small budget, but we work together as practices to put pressure on what the commissioners to bring improved services for our area. At the moment, we're doing some work, particularly bereavement counselling, which was related to this. So we can't guarantee that the palliative care budget is going to be improved from central government, but I think we can say from what's been said, it's still going to be improved by the state.
yeah. I think it's up to us all to advocate for more funding for palliative care and care in the community. I mean, that's our choice and our responsibility. I'll tell you to fill that.
Sorry, I'd also just add to that. I think, yes, we always want more funding to do more, but in addition to that, we're always told, well, can you do anything more efficiently or effectively with the funding that you've got? And I think we potentially could. The ICB has a statutory duty since 2022 to provide 24/7 palliative care to patients. And that's not just the patients in cities, it is meant to be across the whole of the ICB, which the ICB is the Integrated Care Board. So it's the regional provider of NHS care, both in primary and secondary situations. So they have a statutory duty to provide 24/7 palliative care. It doesn't have to be specialist palliative care, so it can be delivered in primary care by the district nurses and the GPs. But in conversation with one of the palliative care nurses yesterday, there is a palliative care consultant on call 24/7 at the hospice, so that they can be contacted for advice if anybody is struggling out of hours. And there should be, and Greg maybe knows this better than I do, but there should be also be 24-hour pharmacy services available somewhere in the region as well, shouldn't there? That's as part of the statutory duty as well. Whether or not it's local to here is a different matter, but these are things that we can hold them to account for already, rather than trying to create more services. Even these things that are already there, we just need to speak up and ask for what is our due right.
Yeah, just briefly,
Just to add, it's actually the best use of resources. So basically, we are a part of 10 doctors who do one in 10 on call, but we cover not just York. So I cover not just York. So York Hospital, Community Hospice, Scarborough, Hull, and Harrogate. So that's how the consultant network works. So it's making use of the consultant support regionally, but make sure that's 24-hour cover. So we'll be able to provide telephone support to all these regions.
Okay, so that's all we've got time for. We're 5 minutes beyond, so sorry for keeping you. There's lots of information here. If you'd like to leave your email address for further information, links and so on and so forth, the podcast and to other resources, then you're very welcome to do so. We can pass those on to you. And just thank you all for coming out on a dark November night, but hopefully on Friday night we'll be in a better position than tonight. So thank you very much, and thank you also for Larry for joining us. Thank you very much for doing it. Okay, Larry. So we'll see you soon. Okay. Thank you so much.
Thanks very much.
Thank you. Bye. Bye.